Yeah, good.
Right, good morning everybody. Welcome to the December CQC board. We have apologies from Eileen Milner and Rebecca Lloyd-Jones, who would normally be here, is also away. And we also have an apology from our new board member, whose name's completely gone out of my mind. Jura, sorry, Jura, if you're watching, completely gone out of my mind. So here's an apology. He was with us last night, been contributing to the board, will be at the next board meeting. Minutes of the meeting of the 16th of November, are they a true and accurate record of everything we discussed? Okay, thank you very much indeed. I don't think there's anything on the action log that we need to discuss. Is there anything arising that anybody wanted to raise that's not otherwise coming up on the agenda? Great. So, Chief Executive, your report, please.
Okay, thanks. Good morning, everybody. I'll do this at some pace, but I think Mike and Andrea may also make a contribution to these items when I get there. So, as is usual, there's a performance report which is for the month of October, where you can see the progress which is being made in relation to the completion of the inspection programme. I'm not going to present this in detail. I think the top line from this is these programmes are on track for completion. You'll also see improvements in the performance in relation to the timeliness of reports. Peter, you and I were questioned on this at the Health Select Committee, and this is the most up-to-date information we've got about the progress that is being made and the further work that is being developed. On registration, I think there's some continued progress here, and I think as the impact of the changes that have been made begin to take hold, that's working its way through in improved performance. So I think there's some positive news from that. We've touched previously on the work that we're doing around improvements, particularly from those that have been requiring improvement for a while, and we set out the work which is ongoing here to make sure that each of these services are covered, and we update in relation to enforcement action. I think the significance of this enforcement action is running at about 11% of our inspections. I learnt this figure as part of the Health Select Committee. Previously we were running at around 6, just over 6 and just below 7%. So again, some evidence, I think, colleagues, that more work on enforcement is being done. In fact, I think at this point in the year we've done more enforcement work than we did in the whole of last year, and it's important to point that out. I think this works through in relation to workloads. So if I pause at that point, Peter, and just ask colleagues if there's any questions. There is a monthly dashboard. It's not the quarterly detailed report, but there's a monthly dashboard that supports a performance report, and there may well be comments or questions from the board in relation to performance on either what I've said, what's written, or on the annex to the report. If I just pause at that.
Sorry, Robert, yes, please.
A question about enforcement, which talks about 1,667 published enforcement, in addition 1,037 enforcement actions in progress, although not all of these will result in a published action. I wasn't quite clear what that meant, in the sense of if there's an enforcement notice or action, is there a reason why it's not published? And if there is an action, why isn't that published? In other words, if it's worth enforcing, why is it not? Okay. Why is it left like that?
It lurks in the depth of the regulations, and Andrea's straining at least to one.
Thank you.
Just to be supportive, David. So this is part of the issue that we have about not being able to publish the enforcement action that we've got in progress, which I think is an issue for us, because we will be taking enforcement action. For example, a proposal to cancel the registration of a provider. That will be going through its process. They have the opportunity to make representations against that, and those representations may be upheld for whatever reason, and therefore we wouldn't end up with a published action. Or we may actually, by force of the notice of proposal to cancel, actually get the improvement that we expect to see. And therefore we would cease taking that action because the improvement has been made. And in those circumstances, we wouldn't be publishing the action because it would not have been completed, because we would have stopped partway through the process.
Well, thank you. That's really helpful. Then in relation to those that are unpublished but produce the positive outcome that you have suggested, how do we reflect those in our performance figures or in terms of our measurement of how effective our impact is?
So that's the reason why I'm saying that there is a problem, because it's very difficult to do that, and as a consequence of we've been pressing on this with the Department of Health for quite some time, and Malta's colleagues in the strategy team have been taking this forward on all of our behalf, because we cannot kind of in a sense demonstrate that because we can't make that public, and so my teams know, and Steve's teams and Mike's teams know, that there are occasions where we have forced improvement through the use of our enforcement action, but that it has not resulted in a published action, and that sadly I think gives the undermines the confidence that the public can have in us, in the fact that we're actually taking action that results in a positive outcome, because in some circumstances they don't see it.
Does the ban of sort of publishing include not sharing the information with, say, a family that's raised the concern that led to the enforcement action, or can you share the information with them?
So we are not supposed to, and there are obviously sort of conversations that we have, and you will see in the comments that we're making about the Morley Group later on in the paper, that we are being clear that we are taking enforcement action, although we're not being specific about what that action is. But it does put us in extremely difficult situations, and one of the issues that I think is even more difficult is actually if we are undertaking that enforcement action, it does come to a conclusion, it does mean that the service is going to close. The people who it most directly affects, which are the people who are living in that service or using that service, if it's a domiciliary care service, and obviously has an impact on Steve and Mike's areas as well, the last people to know about it are the people who are going to be directly affected. And so I think there's a really good reason for us to try and make sure that we can get these changes to the regulations so that we can share that information in an appropriate and timely way.
Thank you. Did you want to add to that, David?
Well, the only thing I'd say is this is why it's important we're pressing for this change in regulations, because for exactly this point, Robert, people could be selecting homes that we're concerned about and taking action on, but it's not public. And the longer it takes us to produce a report, the longer that period runs, and therefore the more likelihood is somebody's going to choose a care home about which we're concerned, but we can't publish. And I think when these regulations were drafted, they were drafted in favour of the provider, not in favour of people that will be using services. So the department is going to change our regulations. They want us to rate things which we currently can't rate, like drug services, and that's the opportunity to get these changes introduced as well. So they do operate in favour of people selecting services. But at the minute, I think anything we say will be deemed to be published. I think what does happen, however, is some local authorities will put a moratorium on, which they can do independently of us, and we do advise local authorities if we're taking action. So there is, it's not completely unfettered in the action we can take, but we can't say we are taking action against this home in this way, and that's what we want to change, and that's why we've been pressing, and so Malta's team are doing that. Andrea raises it. I've written to the department and said we view this as the utmost importance.
Sorry, Lewis, yes, please.
Do you mind if I follow that up? There's a similar question. Sorry, I don't know if you're also answering that, Andrea, but about those locations that have been in breach for more than 4 quarters, where there's an equivalent, I suppose, question about, well, it's 1,601, in fact, at the end of October. So in breach for more than 4 quarters, 64% have an inspection planned. So just checking I understand what that means in relation to the 100%. But the underlying point is the one that I think Robert's raising about who knows this, to what extent this is public knowledge, and in particular how families know that these issues are being pursued. And I don't know whether you're planning to bring this up under discussion about the Morley Group and Panorama, but there's a sort of link together in all of this about how families know what's happening in adult social care in care homes. And what the requirements are for care homes in making families aware of any actions that might be taken or any judgments that might be taken. Because this is about it being in breach, not necessarily enforcement action. And we've had this discussion before in relation to making the ratings known, where unless something has changed, the requirement is to display the rating. But of course, you only know about that as a family member if you actually go to the care home and look at the place where it's being displayed. And that may not apply to most people families who are visiting care home. People can live quite a long way away. When they arrive, their primary focus might not be the notice board. These are we do need to think about how we can improve the general information that comes back to families as a result of our concerns, even when they don't quite reach the point of direct action or publication.
Thank you very much, Lewis. It is a separate point, and we, in terms of answering the point about the 64% to the 100%, there are issues that we're looking at in terms of some of those have already had an inspection, and it's about a data cleansing issue in terms of being clear what further action we're taking and how that it's not just whether we've had an inspection, it's kind of the monitoring that we're doing and the engagement that we're having with the service. So there's more flavour to that than just the 64% that you see there. The second bit of the question, which is the information provided. So in the reports, it will say that the regulations have been breached, and it will say what action we have asked the provider to take as a consequence. So that's set out in the back of the report, and we would have said in the summary that there have been breaches of the regulations, so that people are directed to that. As we have discussed before, there are issues there is an expectation that the summary of the report will be shared with people who are using services, be they residential or domiciliary care services, by the provider. And it's not just the display physically, but also the display on the website that people are expected to do in terms of the ratings. And we have taken action against some services who have not done that within once the 20 days grace period has passed. But I think that the broader issue about how can we better inform the public is something that I think sits very properly in the public engagement strategy that we've got on the agenda a little bit later, in terms of how, because it's not just for us, it's across all three of the sectors that Mike, Steve and I are responsible for. And I think that thinking through things like how do we make the website a lot more user-friendly so that people can get the information, understand, see the history of a provider in a much easier way, etc., etc. There are a host of issues which are underneath, I would suggest, the detail of the public engagement strategy that we all need to pursue.
Do you mind if I come back there for 1 second? I think that's a very helpful reply. I think I just still have a concern that I think we can improve information. Our website can be informative and so on, but the onus is still on families to find out, and that seems to me to be a potential flaw, because you have to know your way about the system a little bit to know where to look, and it would be much better, I think, if there was a greater onus on the provider to inform, and perhaps it would act as more of an incentive. I mean, you do hear stories of the the tricks that people get up to displaying on your website, as long as you've got a website. There are people do extraordinary things to avoid public disclosure of what we decide. And I suppose that's in the end the element of that people have an entitlement to receive the information rather than an entitlement to find it out if they know where to look.
And certainly the way that that's framed in our expectations of providers is that they do give that information, and our advice to them as well is also, if we're saying that they're inadequate or requires improvement, to be clear about what it is that they are doing to address the concerns that we've raised, so that families and people who are using services and their carers actually get the full and proper information. And as I say, we have indeed taken action against people in terms of highlighting to them the things that they need to do, and issuing fixed penalty notices. Where they've not done that. So that it's kind of it's something that we have to relentlessly continue to do, but it's something that we're very, very mindful of.
Okay. Any other points anybody wants to raise on David's report? Okay.
I've got some more things to raise on my report. That was a performance bit.
Right.
So linking seamlessly to, linking seamlessly to the update on the Morley Group and Panorama from Lewis's question. There's just a few brief paragraphs here just to give the opportunity for the board in public to actually have any questions or discussions answered by Andrea or I in relation to Panorama. I mean, these few paragraphs are stating, the factual points that Panorama did a programme of the Morley Group and found concerns via their recording of the quality of care there. CQC was taking action in relation to 2 of the 4 homes in the group. One of the homes was subsequently closed. We continue to take action based on our based on our inspection. It is enforcement action, which for the very reason we've just been exploring, it's difficult to talk about because we are exactly in that position with these homes. So we've tried to set that out to give the opportunity. Right at the end of the bottom of page 4, there's a couple of paragraphs there in some of the work that is going on. And if members of the board have any questions about it, my sense is that focusing on what is it that we're doing in relation to picking this up, it might be the area that you would want to explore, and certainly Andrea is very happy to answer any questions on what it is that we're doing as a consequence of the Panorama programme. I think it picks up on the general point about what we can say where we are taking enforcement, and also your last point, Lewis, which is where there's been requires improvement outstanding for more than 2 consecutive quarters. What does that mean as well? So in a sense, the Morley Group is almost an example of both of those 2 things, and why it's important to sort both of them out. But if there are questions, Peter, and I'll pause at that one, I think, and then I'll do the rest of it apart from the investigations on death at pace, but we'll pause.
Yes, thank you. I think that's wonderful. There's a note in here about working with Department of Health and colleagues partners across the sector, and HealthWatch is hopefully involved and is really keen to be involved, so please ask us.
Yes, we've held 2 roundtables already. HealthWatch have been involved.
Paul.
I was wondering, Andrea, whether you could say a little bit more about how we're looking at groups like Morley Group, which has got issues, where you've got a group with up to 10 or so homes where we've got a significant number which are causing us problems. Because it seems that that's a potential significant risk area, and what are we doing differently now as a result of this?
So what we've done is we've got an analysis of the numbers of groups who have more than 50% of their homes that are either requires improvement or inadequate. Those are being reviewed by the heads of inspection at the moment. And the plan is to each of those groups will have a relationship manager, and what we're going to do is to absolutely make sure that it's the right relationship manager to have the conversations that need to be had. That we will hold management review meetings around each of those groups in terms of, are there consistent themes across those patches that we need to be looking at? Are they kind of at the requires improvement is a range? So there are some that are kind of requires improvement, a couple of requires improvement, but they're kind of getting close to good. There's others that are one inadequate, 4 requires improvement, and some breaches, so that that we'd be really worried about. And just kind of getting the flavour of the risk that's presented to us from that analysis, so that we can determine what the appropriate regulatory action would be, and also to make sure that each of the inspectors that have got those services on their portfolios, because they may, usually these are geographically concentrated, but they may sort of go across local authority boundaries and therefore be on different inspectors' portfolios. Also making sure that we're joining the dots up so that the relationship manager for the groups is sharing that information with the individual inspectors to identify where there might be where it might be appropriate to be going back to those services more quickly. And of course we will be going back to those services that are already inadequate within 6 months, and if there requires improvement within 12. But I can kind of bring an update to the board at the next meeting, or probably more appropriately the February meeting, just to kind of give you a flavour of what that review has done and what we've found.
Yeah, I think it'll be helpful. I mean, are we also looking at whether geography plays a part in this? I mean, are there particular parts of the country where this is more of a risk than others? And is that something where we're thinking about our risk element? I don't know whether, in this case, Cornwall was a very poor area.
So there's a kind of triangulation that we need to do around that. We do already know that we have some hotspot areas where we've had higher proportions of inadequate requires improvement services than others. This is now looking at, is that related to the nature of the group and what those services are doing, and so we can bring that together. There's not a kind of direct answer I can give you now, but certainly we've observed that. And what's been interesting, we've had some areas over the course of the 2 years plus that we've been doing the new methodology where we did indeed identify hotspots, and very kind of concerted action by the local inspection team with the local authority has moved that picture on in certain areas. So kind of making sure that we're picking up on these trends and themes and then taking the action with other partners, local authorities and clinical commissioning groups, and also with providers, is part and parcel of what we're doing.
I guess the issue that would worry the public would be that it took a television programme to expose the nature of the problem. It's not that we weren't aware there was a problem, but the sort of depth of it and the details were discovered once the media became involved. So my question is whether we can learn from that, and whether there is a way in which, in retrospect, even in retrospect, accepting the limitations there, that we can learn, find out whether there were indicators of a greater problem that we might be able to apply in the future. And I think Paul's question is a very good one, because it is about how we understand what it is about the many services which are rated requires improvement, which might signal that there is something more here and we should be looking more. It may be that a group having a series of requires improvement ratings in the same group, that's one of the indicators. But I'm asking that same question in a broader sense, whether we're getting to the point where our prediction could be better, what other information we might need. And I suppose behind that is the question that, can we get information? Is there information available to us, in this case for the family, for example, that doesn't in the end lead us to rely on the media? Because although that might have the right outcome for this particular care home, that's a very it's an unreliable resource, and in the end we can't rely on it in the future, and people will not be reassured by the fact that we then took action. They'll be concerned that that's what it took.
Okay, so what I'd say, Lewis, is that it did not take the Panorama programme to expose the depth of the problem. This was a group of services that we had been concerned about. We had rated them as requires improvement on a regular basis. One of them we had rated as inadequate at one stage, and with the support of the local authority and the clinical commissioning group, they'd made changes which took them out of inadequate and back into requires improvement. So we kind of had that background and understanding. We had already picked up in 2 of the nursing homes, but not the 2 that the Panorama programme went into. We had already picked up that there were increased concerns, and indeed had inspected one and were inspecting another at the point that the Panorama programme provided their information. And in terms of the reports that we've got of the other 2 homes, it is quite clear if you read them that the depth of the problems were exposed by those inspections. I mean, there are some aspects of care that inspectors observed on those inspections which, beggars belief that people think that that's an appropriate thing to do when an inspector is around, and either means that they had no idea that it was poor practice, had not been trained and supported to know any better, or there just simply weren't enough people around to actually do the job properly. And I think it was a combination of all of those factors. So, indeed, Panorama programme identifying that that they had been in and they'd seen that. They didn't share the footage with us, but they did share a fairly detailed letter with us of the concerns. We were already in the process, because actually that group is all kind of looked at by one team, to go back to Paul's point, and we're already in the process of thinking through what we needed to do with the group as a whole. But we brought those 2 inspections forward. They were already planned. So it did not take Panorama to expose, or indeed to push us into a position where we were taking action. We would have been taking action in the face of the problems that we uncovered anyway. However,
Telltale signs.
Yeah, no, I would absolutely take your point about, we do have services that requires improvement. What are the signals that we need to be picking up on in terms of focusing our risk-based approach around when we go back to services and how quickly we go back to services. And actually, with the Morley Group, we have been doing that. I mean, we'd actually been into those places a lot more often than a requires improvement rating might have indicated. I think that we need to look at that history, but we also need to look at one of the other pieces of work that we're doing is looking at services where we have had a requires improvement on a number of occasions, so that we can go into that and to look at again what are the telltale signs and symptoms. At least in one of these services, I think the manager had moved. For me, that is always a bit of an alarm bell in terms of and it was the manager that had started to make the changes that had taken them out of inadequate previously. So I think that there are things like that which we need to make sure we're picking up on, which we would do because of the registration of the managers, and that we're feeding that into inspectors, and that we are using that to bring forward our inspections as we need to. There may be other things that we'll uncover in the work that we're doing, and the plan is to use this activity, which we would have wanted to do anyway, to feed into the consultation that we'll make about the development of the next phase of inspections for adult social care. That consultation should happen March onwards, with implementation of new changes from July onwards.
Michael.
I have wondered whether there is a way of signifying how serious a requires improvement rating is. Because at the moment there's this, you're either requires improvement or inadequate. There's kind of nothing to signify how much improvement is required. And I think what Andrea is saying is these homes where we had already inspected required a lot of improvement. Exactly what tips them into inadequate is a difficult question, but signifying, and as I say, I haven't got an answer to this, but finding a way to signify that the extent requires improvement, or at least that requires improvement is very extensive and deep, I think would be helpful to relatives. Now, as it happens, in the Times articles on adult social care this week, there was a kind of insert about a care home in Yorkshire called Fulford, the Fulford Nursing Home, which we have rated as good. Actually, we rated safety as requires improvement. And if you read our report, you just wonder whether that really requires improvement, or, because the improvement required was so modest, should that have affected what was clearly, an excellent home? So sometimes, we've got modest requires improvement, as I think in the case of Fulford and safety. Others, like the Morley homes, where it requires improvement, actually is very serious. And our ability to distinguish between types of require improvement has struck me as something we may want to think about.
And I think that the way that we do that at the moment, Michael, and I'm sure there are things that we can do to improve, is in the reports we will be saying what it was that actually made that service as requires improvement and what we have asked the service to do. So there will be clarity in the report of that. And so, if it was something relatively minor but actually still needed to be sorted, and I think it's important that we make sure that we don't duck the issue, even in a good home, of the things that they can do to improve and ensure that people are protected from harm and abuse and neglect. We need to be doing that, but the clarity that should be there in the report. The second thing I think is the report will identify the range of is it requires improvement across the board, or is it kind of in minor areas, in a minority of areas, sorry. So that will be visible on the front page of the report, and that will be clear to people. One of the issues that we do have, which we're exploring with the publications and digital team, is, as you know, if somebody has had an inadequate rating in one area and has inadequate rating kind of 2 times in a row, then actually they go into special measures as well, and we don't make that as public as there's not something that designates, unless you go into the detail of the report, that they are in special measures. So there is something I think that we can do that can clarify that one as well. And last but not least, it goes back to the point that I made to Lewis, which is that we obviously identify where there have been breaches to the regulations, and that's where there requires improvement. I mean, I think is kind of signifying that the more serious end of requires improvement is where we've got breaches.
Thank you.
Just slightly, sorry. I suppose the concern is that a relative will look at the headline or the headline ratings. And I think Andrea's point about breaches, maybe that should be part of our front page or emphasised in some way. So to, as I say, without adding another rating, find a way of strengthening the severity of a requires improvement.
I'm sure that that's, I mean, we're at a stage with both publication in terms of what the report looks like, but also what information is available on the website of looking at that with various members of Malta's team. And, I think all of us understand that our website is not as user-friendly as it could be in terms of giving people the information quickly and easily, and there are things that we want to do to improve that. And this is certainly one of those areas that we can take into consideration, Michael, I'm sure.
Good. Robert.
Just not specifically about this group, although maybe it prompts the question. Some of these groups have really complicated corporate structures, and I don't want to go into. But when incidents occur in relation to a home, which is a part of a structure, it might give rise to questions about the fitness of directors to be directors under the regulations. Now, in the health sector, for better or for worse, and it may not work terribly well there, but we're looking at that, there at least is likely to be a large enough group of people to actually start considering that within the organisation or in the surrounding structure. The adult social care sector, I sense that's not the case. So who prompts the consideration of that question? Do we, or does someone else, or do we just leave it to the board of the relevant organisation to think about it for itself?
As you allude, Robert, it's different in different circumstances because, as you know, we range from services where there's one or two services all the way through to significant corporate structures where there's lots of layers and lots of governance around those layers. So it would be there would be a variety of different things that we would take into consideration, both in terms of what we might do individually because of the service, what we might do in the relationship management that we have with the corporate structure in terms of highlighting things, but the limitations of the fit and proper persons regulation apply in adult social care as well as they do in health, and it is a challenge for us to do that because, of course, it is the expectation that it's the organisation itself that assesses whether people are fit and proper, not that we do that assessment, but that we ensure that that assessment has been done. So, and there is something that is tricky, particularly in the smaller areas, because that sense of independence is not necessarily there, where we therefore may have to take a much more proactive view.
But what I was really getting at, understanding those are the issues, and one might wish to revisit the regulation, but that's another issue. But given what we have, do you feel you are able to, as it were, at least precipitate a process being taken?
Can I jump in? So if you look at the second page of the performance report, bottom left-hand box, you'll see that I think during the year we took 56 management review meetings, which resulted in 24 enforcement actions in adult social care on fit and proper people with directors. So I don't know whether that's a big enough number, a small enough number, but it is a sense of, I think, what may be behind your question, Robert, that we are indeed taking action in relation to this. And the review of fit and proper person, for me, has got to be of the totality of our responsibilities, not just in hospitals and the acute trusts. There's some figures there for Steve's area as well as Andrea's area, and we need to look at it in the round as well.
Okay. David, do you want to move on?
Yeah. What?
I don't know if you want to go to Mike or...
I've lost my page. I'll be with you in no time whatsoever. So I'm going to do this at some speed now, if I may. So 3 and 4, there's no regulatory updates from hospitals and primary medical services. In a sense, touching on the issues that we've just been exploring about what do we do with services which requires improvement. And I think there's been two aspects to this of previous discussions. One is how do they improve and what are the factors of improvement, and why do they not improve and what are the factors of that. And there was an outstanding minute which had Paul Bates' name against it, which has kept coming back on the action log. So what I'm trying to suggest in this paragraph is this is how we will deal with both the quality improvement, and I think Andrea's contribution to the conversation about Morley and requires improvement also contributes to this. So I hope the board have some sense of this issue is being progressed, and we'll take it forward. And I think it picks up some of your points, Lewis, about getting an understanding of what's behind some of this. Staff survey is now out and in the department and is being brought together. It comes to the executive team next week in its fullness. We've now, I think, got all the analysis from the survey company, and I have to say it's been the best analysis that I've seen in my time at CQC and the work that they've done, and that will come in full and will be published in full in the board meeting in January. So I just wanted to update on that. And then the rest are place markers, in a sense. Peter and I went to the accountability meeting. You can watch it on the Parliament channel if you've got nothing to do for 3 hours. Important issues are about our performance and our future direction were explored by a good turnout of MPs, and a pretty full 3 hours, I think, we were there. Experts by experience. I continue to update the board in relation to this. My update this month is brief. I've shared previous correspondence. We'll do that publicly as well. But we continue to monitor performance of the contract, and the performance is improving across the range of the contract with Remploy. And then lastly, colleagues, I'm just logging the publications that we've made since the last board, the Monitoring the Mental Health Act, which I had to say I thought had some profound and important things to say, which we will follow up in subsequent reports over the next 12 months. Some quite different ways of working, combining, speaks to the new models of care and our strategy, combining the way we look at urgent and emergency care by not just looking at GPs or ambulances or 111s, but by looking at the range of services and how they sit together. And then the third item here is the review and investigation on deaths that Malta's team have largely been responsible for drawing together and consulting with people who use services, running surveys and questionnaires of staff, and Mike ably fronted yesterday in terms of presenting this. It was well received, I think, by the media, by a number of groups. The Secretary of State accepted all the recommendations when he made a statement to Parliament, and the work is there. So, again, I may pause at that one, Peter, because it's the first opportunity the board will have had to consider that, the other reports you've had. The last item here is a consultation document, and we will, as a board, return to that and or will be revealed as a result of those deliberations. But if I just pause for Malta and Mike on the investigation of the deaths. I thought it was an excellent report, by the way, as well.
So, Mike, do you want to say anything?
Shall I just give a very brief overview? I suspect board members who've had any time will have now seen the report. Everybody, I think, knows that it stemmed from the tragic death of Connor Sparrowhawk, and then from the Mazars report that looked at Southern Health, and then we were asked by the Secretary of State to look across acute community and mental health trusts, not just at people with learning disabilities who died, but obviously there was a major focus on that. We surveyed all of the trusts in the country. We went on visits. We engaged a lot with families and carers, and I'd like to say a particular word of thanks to all the people that we've engaged with, but particularly the families who spoke eloquently to us about where the system has been failing. And we had really asked 5 key questions in our whole review. First of all, how well are families being involved? Secondly, and it may sound strange, but how well are we identifying deaths? And that's relatively straightforward if somebody dies on your premises, but if somebody dies elsewhere, the information may not get fed back to a relevant trust. The third question is then, how do we decide whether an in-depth review or investigation is needed? Fourth question was, what is the quality of investigations when they're done? Fifth question was, are trusts learning from this and taking action? And the the truth of it is that we found there were failings at all 5 different steps, and as we said yesterday, we didn't identify a single trust which is getting all of those steps right. There are some trusts that are doing a great deal better than others at one or more of the steps. So we've made a number of recommendations. As the report was a report to the Secretary of State, as he'd commissioned it, he then made an oral statement to Parliament yesterday where he's accepted the recommendations, as David was saying, and action will now be taken, and from the end of March, the boards of trusts are being charged with collecting information on deaths and setting out what learning and action they've taken from that. They're being charged to undertake high-quality investigations and to collect information in a standardised format. There's a lot of work to be done to develop a national framework, which the National Quality Board, which I co-chair, will be overseeing. There are training issues which Health Education England will lead on, and then there's the specific issues related to learning disabilities, and again the Secretary of State made comment on that in his statement about the rollout of the programme to learn about learning disabilities and people who've died from them. I think it is also important to say that we need to take action. We can and will, as a result of this, strengthen our own assessment, and we've put that into the report. We will have a particular focus on looking at how well deaths from learning disabilities and people with mental health problems are being investigated by trusts. We'll look at the quality of the investigations. We will look at the reports that are going to be going to trust boards, but importantly we'll be looking at what action they're taking on it. And throughout this we'll be saying, are families being involved or are they not?
Mike, thank you very much. You actually managed also to answer the couple of questions I was going to ask, so thank you for doing that without even a prompt. Anything, Lewis?
Well, first of all, I think it was a really good report. I think I was the board sponsor. I was certainly consulted quite a few times about it.
You were.
I thought it was a really good report, and the team, including the people who aren't here, deserve a lot of credit, actually. I think they if you read the analysis of what is going wrong, it is a very, very good and detailed account of why the system hasn't worked well. It may well be a landmark report, as lots of people were saying. In fact, I think even I said that in social media, but I was getting carried away at the time because it will be a landmark report if it makes a difference. And so we have to have confidence in all the groups who are now responsible for taking it further, the NHSE, NHSI, NQB and others, and ourselves. So Mike, I just want to ask you about what you finished with there, which is how it will affect what we do. There is a sense in which improvement, it is right to set out what needs to be better, but it will depend on certain people doing things differently and taking on roles that they haven't previously taken on, or at least not in the same way. And so exactly how family representation will work, I think, will be important. Who's going to ensure that happens? You know, that people have talked about an advocacy or liaison model, and getting that right will be really important to making a difference. A lot of the difficulties that arise, in my experience, is that right from the start the families often aren't consulted, and therefore everything else goes wrong after that because the wrong questions then get asked, the right learning doesn't happen because the right questions weren't asked, and so on. But knowing what families want to know is a really important starting point for an investigation, and making sure that they have the opportunity to feed in and so on. All of that is crucial to your eventual point, which is about learning. So my question is about CQC and what will we do to make sure that role is developed as well as the sort of broader intention. And similarly, on who will be responsible for ensuring that learning happens. The report makes reference to board members having a responsibility there, and that is a very important point. But who will oversee learning? As you know, make a learning organisation. So I just want to get your view of whether we will look specifically at the development of those roles, how they're being worked up. And I've got one other point as well. Of course, this is about what happens when people die. But the implications of how people are looked after when they're alive. And so the question is, how will it affect our inspections of current care, not just of how deaths are investigated? And if you remember, going back a couple of years to when we first started planning investigations of the inspection model, the new inspection model of the acute hospital, we did talk about whether there should be a kind of weighting of the way we inspected to take account of the fact that there are disadvantaged groups in the system. And in the end, we didn't go for that. But I must say, I want to ask the question again, whether if there are inequities in the system where people with learning disability and people with mental illness don't get the same level of care, so there's a health inequality there, whether we can really address that unless we deliberately set out to tilt the inequality the other way. If we apply the same model to everybody's care and ask the same questions about everybody's care, that runs the risk of perpetuating inequality because it isn't trying to change it. And I just wonder whether we should be saying more forcefully to acute trusts that we will take a particular interest in how they provide acute care, general health care for people with LD and mental illness, and that will feed into their ratings. It isn't just going to be a question, it's something which will have a direct impact on their ratings. If you remember, I wanted to make it impossible to get an outstanding rating unless you could demonstrate that this is an area that you excelled in. And I'm still asking that question, whether that would be an appropriate response to this.
I lost count of the number of questions that are actually embedded in that. But I absolutely agree with you about the business of getting it right from the start. And that was a point that was actually made by a colleague of yours, Simon Wesley, when we were consulting on this before publication, the importance of that first conversation. One thing I left out of my very brief summary of what the Secretary of State said was he has accepted the recommendation that there should be a board-level leader in each provider organisation. That is somebody who we would undoubtedly want to talk to as part of our well-led assessment of a trust. And we would want to say, OK, now, what have you done to make sure, first of all, that you can identify people with learning disabilities who may have died in your trust? Secondly, how are you involving families? Can you give us examples of that? Thirdly, what have you done to train your staff to do the investigations well? Let's look at the reports that you're taking to the Trust Board and, as I said before, most importantly, what action you're taking on it. So I think we will have that focus, and we've said we will. It's on page 9 of the report what CQC will do, and we will do that. I think going back to your point about are we looking at learning disabilities well enough in our general inspections? We do, of course, already look at this within the responsive element of our inspections. It doesn't just apply to learning disabilities, it would apply to people with dementia, and I think you could also argue that other physical disabilities should be in there as well. And I think it is certainly an opportunity to say in all our inspections, are we looking at those people with individual needs and are we giving them sufficient priority? I have always resisted the idea of any one thing being a limiter on a rating, but I think we can come back to that. But I do think we are already looking at it under responsive, and we are finding that some trusts are better at it than others. You know, we ask the questions, for example, with learning disabilities. Could you tell me who in this trust has got learning disabilities, who's an inpatient now? Is that flagged on the patient administration system? Do you have a learning disabilities nurse specialist? Would they know who the patients are in your trust with learning disabilities? And what reasonable adjustments have been made for them? You know, for example, if they're having surgery, are they being put first on an operating list? Those are questions that we developed with Dominic Slowey, the National Clinical Director for Learning Disabilities, and those should be being asked in all our inspections.
Thank you. Robert.
Apologies. Very briefly, I echo Lewis's comments about the quality of this report, and I'm grateful personally for the opportunities I was given to comment on it in advance. particularly as the issues that it highlighted echo quite a few that I found in Mid Stafford, and which brings me to the point about what happens to reports. This number of years after Mid Stafford, the problems in relation to investigation of complaints, of incidents, of deaths, still has to be fixed, and this report is part of the picture. And I appreciate that a lot of steps are now being taken towards that, but I personally cannot rest until, as Lewis puts it, we not only know what the problem is, but we have actually fixed it, and we are seeing results coming out in terms of the effectiveness of the care given to patients and service users. The only question I therefore have is can we, as an organisation, we may have distributed responsibility for doing stuff to lots of other people, and we have some stuff to do ourselves, but could we as a board please be informed in, say, a year's time as to what progress is being made in relation to both this report and this field generally?
Yes. Are we then happy to move on? Good. So, Chris, come and join us, Chris Day. Everybody knows. So the public engagement strategy, Chris, I don't think you need any further introduction from anybody, do you?
I'm happy to. This is an early insight into some of the themes that we've been developing with partner organisations as we begin to do some early consultation on the development of this strategy. So I wanted to make the board aware of where we got to with the development of those themes. Probably the two areas particularly to note in the report. Firstly, under item 4, our ambitions. When you link this back to the CQC strategy, we've talked with organisations and with people who use services about how we support and encourage improvement. CQC are a member of the People and Communities Board, a sub-board of the 5-year forward view, and that group's role, working together, is to understand what's driving improvement and how we can get the voice of people who use services into that improvement story and strengthen our collective voice so that we can drive the right behaviour and the right change in organisations. And that's something that they, as a group, they're keen that we explore as part of this strategy, and I think it links well to that, the first strategic ambition. In terms of an intelligence-driven approach, we've been speaking to colleagues at HealthWatch, and we've been speaking to other organisations as well about how we join up the voice of people who use services so that it can amplify what we know about services. We've been historically good at collecting hard data, but the ability to collect the voice of people who use services and use it well is something that we have to do as part of this strategy. And we've been having good conversations, particularly with HealthWatch, about how we can join up that understanding so that we can present back to our own organisation and to others a comprehensive view of what people think of the services that they are using, and that in itself we think will help drive the right behaviour and the right change within those organisations. In terms of promoting a single shared view of quality, it's very important that we are. I think a lot of this is focused on how we share information across a system, and that is very important. It is also important that we make that information meaningful to people who use services. So at the moment, a lot of our activities based around inspection reports. It's important that we can lock together what information we see on inspection reports and the constant stream of information that we and other organisations will get. So we have an always-on view of quality that links those two things. And lastly, and obviously, we need to improve our own efficiency and effectiveness, and I think that's about how we find the right partnerships to do the right thing. So all those ambitions that we have there are organisations who can support us in that, and we can work collectively, and I think more effectively and efficiently. And if that brings me on to the changes that we're proposing to make, they sort of fall into 4 areas, but there are 7 changes that we plan. The first one is about how we support our teams locally so that they can effectively engage, as they do anyway, regionally with local HealthWatch, with other organisations that represent the views of people who use services. And also, how do we use the the people that we have as part of the Experts by Experience programme and others, so that they can give us their view of the services that they experience. It's an untapped resource at the moment that we need to make the most of. We know existing sources of qualitative information that come from a variety of sources. I think we need to bring that together more effectively than we do. We've been talking as a transparency board with VH, which again we're a part of, to try and bring together the information that other organisations have. So we have a well-constructed, easy to understand and act on view of how services are developing. Clearly our digital engagement is important here as well, how we engage, how we use the technology that we have available now that wasn't available 2 or 3 years ago to drive that engagement. It's not just about the website, it's also about applications-based technology as well. Recognising not everybody can engage digitally, and therefore it's important to have the channels both directly and indirectly with people who aren't able to access digital channels. In terms of partnerships and campaigns, this sort of goes back to finding the right way to amplify the message, and we think that we can work better both with colleagues from HealthWatch, but also from other organisations as well as a national group of stakeholders where we feel we've got joint ambition to drive improvement in services, and how we make that happen, how we share our information effectively so we can drive that understanding will be very important. And that's about sharing information, sharing of evidence of what we know, so that we and others can act collectively. And obviously I've mentioned this a couple of times, but the closer working relationship both with HealthWatch England, but also local HealthWatch as well, as a tremendous network of people who are able to provide support. And there are other networks as well which exist that we need to tap into, build confidence and trust with, and then effectively use. The last 3 points, we've begun to do some work on co-production. I think we've in some areas we've been doing this for some time and doing it very well. I think it's about how we have this ambition within all of our work, so that we genuinely involve people in the design and development of our work, and the consultation and the work that we do post the consultation will be a part of that approach. We've got it's got to embed a public focus culture across CQC, and this goes back to my point about hard data and soft data. I think historically the organisation has been better at understanding and using hard data. I think the way we use soft intelligence, and to be fair, the technology that is now available to help us bring together soft intelligence in a meaningful way will help us make that change. And the content I've already talked about, the idea of having an always-on view of quality, needs to work from the person who's using services, wants to choose or just wants to understand what they should expect from their services. So how we develop that, how we share it with other organisations. So although we get 4 million hits a month to our site, we're not the only organisation out there that can provide this information. So how we support other organisations in their ability to share that information. So that's the work that we've got that's ongoing. Those are the changes that we're thinking about in terms of the development of the strategy. We want to continue the conversation with organisations outside CQC, as well as staff and experts by experience who are involved with CQC. And it's brought today for your thoughts.
Thank you, Chris. Really good paper, really good introduction. Anything anybody wants to raise? Paul.
It seems to me what this is about is seeking a much richer dialogue, so people will be able to get at our stuff more easily, and we'll be able to get at their stuff more easily, and the stuff's a different sort of stuff. Theirs are, as you say, a series of qualitative issues, and ours is a series of quantitative issues. And between 17 and 21, one would expect, with the nature of the changes in new technology, there to be sort of at least 2 big technological shifts. The sooner our website is not 10 years old, the quicker it can get into the next period of time and then be changed again. Because if there's 4 million people going on it at the moment, they are really heroic, because it's not easy. So it really, I mean, even if it's just made a bit easier, because in 3 or 4 years' time it's going to be made, it's going to be transformed again. So I think some initial transformation of that would help that dialogue a lot.
Really, it's a very important point. Two things I say in a different guise. I had conversations about the IM&T strategy. I sent David a note this week, which the sometimes difficult process of getting approval to spend money on the development of our website is something that has given me more grey hairs than probably any other part of my job. You
obviously dye your hair.
No, it's just there. It's there at the sides. It's there. It's coming slowly. In fact, more quickly than I would like. It may, as I say, the approach now from the DH is much more positive. They are supporting the development of Alpha We've done some good discovery work. I think I brought this as part of the IM&T strategy. We've done some really good discovery work. We know exactly how we need to change the website. It is not fit for purpose in its current form, but we've known that for some time. Having said that, the satisfaction of the website is actually relatively strong. People, for the thing that if you want to go and look at an individual organisation and you've got a sense of where you're going, it is relatively strong. But it needs to be far better. We know that. We know exactly how it needs to change. We've now got support from the DH to begin that work, and in earnest, we need to be progressing that before or at the cusp of the new financial year. And we recognise there's probably 2 other shifts. The other thing is applications-based technology will actually form a part of that going forward as well. So it isn't just about the development of our own website, it's also how we support the development of our information into others' sites as well. But you're right.
Jane, you wanted to raise something?
Yes, just very briefly. I mean, I think this paper, and it was lovely listening to Chris giving us all those name checks. HealthWatch. Did you mention HealthWatch? I think you might have done. But this has been the real prize of ours, being able to work really closely together. And I think the phrase people used to say to me when I first arrived in local HealthWatch was that we're there when the inspectors go home. And that's true, and of course it's even more true now as we're moving to a more risk-based inspection. So basically, power to your elbow, and we stand ready to help.
Great, thank you very much.
Robert.
I too think this is a good step forward, and obviously there's huge challenges in actually making this a reality, which will lead to grey hair if you haven't disguised it already. But one point I'd like to emphasise, which is undoubtedly here, which is about finding ways of listening to those who perhaps aren't very good or have no resource to get into even the most modern digital technology, let alone the old one, who are perhaps on the peripheries of the health provision or social care system in any event. At a time when we learn through all sorts of things that have been happening recently that there's a mass of people out there who are not only don't feel listened to, but are not listened to. And it seems to me that we have a really important role in relation to health to reach out to those people. And I would just put a sense of caution in that I think it depends on more than developing experts by experience in order to do that, which is, I think, the only place where people in vulnerable circumstances are particularly mentioned. And I know that's not meant to be an exhaustive description of what we do, but outreach through HealthWatch, through other means, through organisations and partners to those who are not normally listened to is a really important part of what we need to do here.
Just to respond, I entirely agree with you. I talked earlier on about the development of partnerships, both national and local. And I think I mentioned trust as well. And I think in development of those partnerships, so we met with a group of organisations, probably about just under 100, that represent small and large communities across the country in regional areas as well as national. And they represent people exactly as you described, who wouldn't be able to engage in through normal mainstream channels at all. And what we have to do, what's incumbent upon us, is to build the trust of those organisations so that they allow us to use their channels to engage those individuals. And I think, ironically, some of the work we've done on thematic reviews has begun to build that trust. And I mentioned at one of these groups about the idea of using information that we know, things that we know, to help them, and then they can help us build on that knowledge more. And I think there is a really important reciprocal process that we go through, so we know the groups and organisations that can provide the right information to us, and also we have the ability to share that information back with them. We held a number of conversations over the summer with some of those organisations, and that was a very important point, the reciprocity of our relationship. But it is built upon the trust, and they've got to trust us, and we've got to act on the information. But I entirely agree.
Okay, are we happy to approve the next steps for this strategy? Yep, good. Chris, thank you. It's really great. Thanks very much indeed. So, Susan, welcome. Jane, you've already been name-checked a few times, as you pointed out, but now's your chance to talk about HealthWatch yourself.
Thank you very much indeed. So if you'll permit me, Chairman, just a couple of end-of-first-year reflections. And perhaps a reminder to us all that what this is about. The prize that we're trying to get here is a health and social care that people can understand and can use. And when Susan and I sat down at the beginning of the year, I think we either intuitively and gradually over the year more explicitly had sort of three watchwords. And forgive me, I was writing this while there was a carol service happening yesterday, so this sounds like a pre-Christmas sermon. But they were truth, simplicity, and focus. Truth, because we really, really wanted to find out what people were actually saying out there. Susan's going to talk in a minute about our new intelligence framework. When we first started cranking it out, the things that were coming out of it, we thought it would be about primary care access and mental health, and the things that were coming out of it were about hospital car parking charges, or catheter management. So it was interesting to really, really try and get to what people actually thought. Simplicity, we had a machine, we had a system which, as I described it in my report, should be just as simple as 1, 2, 3, but in some way we were making it started to look over-intellectualised, and we had to sort of strip it back to essentials. And focus, well, we absolutely wanted to make sure that we had a grip on our structures. And there's some trite phrase that I was trying to tell on Susan yesterday about this year we've rebalanced, we've refocused, we've restructured. But that, in essence, is what we've done. So I'm going to let Susan in a minute talk about the intelligence. I think what I really want to say is a big thank you to Susan, because Susan is, I can't believe I'm saying this either, is retiring, in quotes, in early January. And Susan and I have had a really good year, and I hope that people feel that we have done something useful. I know certainly Susan has done amazing stuff to make this HealthWatch of ours that we both love, to make it more relevant and more useful. So I pay a huge tribute to Susan for that. And thank you to CQC as well for making us welcome here. I think I've said that already, but I will say it again. And also a welcome to Imelda Redmond, who's going to be our new National Director coming from the beginning of January next year. Just lastly, if I can just have a couple of seconds looking forward. One of the things that is, I know Sir Robert will probably ask me this question in a minute, but one of the things that's constantly capturing our attention about the network itself, about local HealthWatch, which is our concern, is the funding. Now, it's not, we're not getting to that tipping point moment that beloved of Andrea, but there is emergingly clear evidence that in more deprived areas, the local HealthWatch is being more stripped back of funding. So that's going to be one of our concerns going forward. I'm also very keen that our business is engagement, and I would like to see us somehow not make more of it, but to really harness the expertise that has been gathered by the system that was set up was very much let 1,000 flowers bloom. So we have 148, 150 local HealthWatch all doing engagement in a myriad of ways, some better than others. So we want to harness the best of that and really start pushing that forward as an expertise. So that's really what I wanted to say, and I'm going to hand over to Susan. Thank you.
And I'm aware that we're quite short of time, so I will be brief. But I just wanted to say, I'm going through our priorities again. Priority 1, you'll see from the report, STPs are a big focus for us at the moment. And we've been doing a lot of work with the network to make sure that they can They can get involved in a number of ways because they can either help with the engagement or they can advise on it or they can critique it and be a critical friend to the organisations who must make sure that they're involving the public in these changes. And I think the engagement strategy is a timely reminder, actually, that we must not be completely distracted by the STP agenda and forget the risk agenda, which is what we really need to work with Local HealthWatch on to support your new inspection strategy. And I think the other thing I wanted to say on priority one is just that our relationship with Local HealthWatch, I feel this year has got stronger. I feel it is more honest, it's more trusting, and we have had very many more mature conversations, and for that I am very happy. But I think the challenge for us going forward, as Jane has alluded to, is consistency, so that we can actually make it easier to gather the information that we're so desperate to collect from people. And going into that, and priority two, we have had the first trickle of information coming through the CRM system, which is really, really exciting because that's what we're here to do. And we are creating our first report, which has come up from that bottom-up collection of information, which will be on dementia. And although we've had reports in the past, and I'm not saying they weren't good, but they weren't collected in that way. And that's what Jane and I have strived to get into place this year. It's that bottom-up collection of information from Local HealthWatch and the conversations they're having with people. Then on priority three, I have been really quite busy in the last few months on this restructure with a very, very busy consultation with the staff, and we've been looking at the proposal and have come up now with a final structure. We have just a few jobs to regrade, and then we'll be having a matching panel on the 4th of January. And so I hope that by the time Imelda starts, I can hand to her a more stable situation with just some roles to be finally decided. And I wanted also, within priority three, just to focus a little bit on the relationship that we have with CQC, and just to reinforce the thanks that Jane has expressed, Peter and David, to you and your board and your teams who have made us so welcome and have supported us tremendously well. And it's wonderful to come to this meeting and hear HealthWatch being spoken of so freely, and also within the equality, diversity and human rights work. I hope you've seen that we have been fully engaged in that. But there is more that we can do to work together better, and so I have made sure that that is written into somebody's job description in the future, so that we keep focusing on that, because it's terribly easy in the busy days that the day jobs that we have, to forget that we need to keep working on some of those things. So I'm not going to say any more, but a very big thank you, and it's been a pleasure, and it's goodbye from me.
So, Susan, I was going to say that there is an absolute mutuality of interest. So the reason that you have been really welcome is not just because you're really nice people. That, of course, is part of it, but actually the information that you bring, both Local Health Watches and then through you, HealthWatch England, as we have said several times today, as David and I said several times to the Health Select Committee, is really, really valuable. And the more that we try and focus our activity to where the problems are, the more we need the information to know where those problems are. So I think what you and the local health watchers are doing is really important. So thank you from us as much as the other way around, I think. I was also going to wish you really well. I'm going to correct what Jane said, because Jane said you were retiring. You're retiring from CQC. That's not to say you're going to retire altogether. I'm quite sure you'll find other things to do. So in the next phase of life, I wish you really well. Was there anything anybody from the board wanted to raise in relation to the HealthWatch report? Well, I said it all. Perfect. Susan, thank you again. Very best of luck. And thank you as well, Jane. So, for the board, board members, is there any other business that we have for this part of? Oh, sorry, I rest out the RGC. Michael, for the RGC, would it be sufficient just to note for the minutes that we had an in-depth discussion on matters that relate to the consultations that we will be releasing in due course? Is that a sufficient summary? Perfect. Good. Well, I said it for you so we can move quickly to any other business. I'm sorry, I nearly left out the any other business. Robert, you look as if you're about to raise something.
Thank you. I just thought I probably ought to report in 1 minute on the National Guardian, because we have now had the first meeting of what we, I think, are calling the Accountability Liaison Board, which is basically representatives of the three stakeholders who are responsible for, as it were, overseeing the National Guardian. And that was a productive meeting. We received a report from Henrietta, the National Guardian, about the work she's been doing, the recruitment for her office and so on. We learned that about the setting up of networks of local guardians. But the point I want to highlight is that to date we think that 188 trusts have appointed a guardian or a group of guardians or whatever, which we think leaves about 52 that either haven't or haven't actually said they have, which probably means that they haven't. The date is now long past when actually that should have happened, and I just flagged that up as a potential area for concern, which I hope we will be reassured has been dealt with by the next time I'm able to report to you. This isn't the report of the National Guardian, who in due course will be reporting directly to this board, but I just thought you'd like to know there's that amount of progress happening.
Good. Thank you very much indeed. Any other business for the board? Great. Good. So, David, your hand shot up incredibly fast.
I'm David Hogarth. I'm the coordinator of a befriending charity in North London, and I'd like to go back to the Morley story and to take issue with Andrea when she says that it didn't take Panorama to get to the depths of the problem. I think those of you who watched that programme, the part which may have made you most sick was when you saw those two members of staff in Clinton House. One was a care assistant. A dementing woman was crying out for help, and she just said, "Don't be naughty, I'm not having any more of this misbehaving." And then we went on and saw a nurse who, again, there was obvious a case of a man being miserable, and all she could recommend was giving him a chemical cosh. And you did not discover those things. Panorama did discover those things. Because when you look back at the report, yes, you did require improvements in things. I was trying to find out what they were, but you'd taken those reports off the website, I think. The caring domain for Clinton House in the most recent report was good. And if you're saying that those two people were not there that time, then that's fine. But my guess is, since it was, I think, last April, that they were there and you did not discover them. Now, you talk a lot about getting thousands and thousands of people ringing up your customer helpline, and about getting information from HealthWatch, and about how you're improving your inspecting. But the fact is that you are not actually discovering these things. It's other people who discover them. Unfortunately, there isn't enough money for Panorama and the Daily Mail to do all the care homes. That's what you're supposed to be doing, and you are not finding those things. Now, in the past, I have mentioned that you should be more like MI5, causing a certain amount of merriment, and even I saw a certain amount of joke in it. But the fact is this, that if MI5 had been looking at Morley care homes last April, I guess that they would have discovered those two nurses and done something about it. And as a result, the two people who were being mistreated would have had a happier life. And although you may laugh about MI5 and say, oh, well, we wouldn't do things like that, then the blame for the increased unhappiness of these people and many other people in care homes all over the country is squarely at the door of this board.
So, David, we've had this conversation numerous times in the board and privately. The difference between us, fundamentally, is that you are suggesting that there should be covert surveillance of care homes, and I'm saying that there needs to be a balance between that and care and the dignity and respect for both patients and staff. So we have a fundamental difference. I said at the last board, you and I will not agree on this, and we can laugh about whether it's MI5, but that is fundamentally the difference between us. So that was the first point I wanted to make. Second point is absolutely fundamentally, and we've made this very clear, we do rely on information from the public, and that is from the media, from social media, from service users, from their families, from other professionals, to provide information as well as what we find for ourselves on inspection. So I don't think it's a problem when somebody is telling us something that we need to look at. It's actually part of how we have to operate. For kind of the reason you said, there isn't resource for Andrea to have an inspector in every home 24 hours a day, 7 days a week. So I think it's part of how this has to work, rather than it's a problem. Final point, and then Andrea may or may not want to add anything. Whilst you are right that of course individual incidents that we weren't present at may have been filmed by Panorama, Andrea's point was earlier in the board meeting that we were well aware of there were issues, there was work underway, and we would have got to the same point with or without Panorama, and I think that's quite an important distinction, what you were saying. I don't know if you want to add anything, Andrea.
The only thing I would add, Peter, and thank you, is to say that there has to be an understanding of the limitation of what we as a regulator can do, and we cannot person mark every care home, every organisation, every hospital ward, every GP practice. So there has to be an understanding of the role that we play, the expectations that we can set, the way that we do our monitoring, the way that we do our inspections, and the way that we provide information to the public, and the way that we take enforcement action when that is necessary. That is our very clear commitment. It's set out in everything that we talk about, everything that we've written in the various strategy documents, and the way that we carry out our job. The fundamental thing about this is that there is an organisation, which in this instance was the Morley Group, but in other instances are other services across the country, that receive money either from the public purse or from individuals because they are self-funding their care. And they have a responsibility and a legislative duty to deliver care in the right and proper way, and to make sure that they're using those resources to deliver care in the right and proper way, and to make sure that that they have sufficient numbers of staff, that they are training those staff, and that they are supporting those staff to deliver care which is both compassionate, treating people with dignity and respect, protects them from harm, neglect and abuse, and actually makes sure that they have a life and not just a service. And I think that one of the things that we need to do as an organisation, as a board, is up our game in all of the various ways that we need to, but we also need to make sure that people who are responsible for delivering that care do it in the right and proper way, and that they take their responsibilities seriously too.
Sorry, I'm going to move on, David, because two other people have put their hands up.
Peter, just one point I think is important. Our previous reports are on the website, even when the latest report has been archived because the home has been closed. If you go to the top of the page, for any home, you will see reports. And if you click on reports, you get every report.
I have done that, but in this particular case, I could not find those particular reports.
But I've looked at St Teresa's, Clinton House, and we have on the website got all the... Well, this is an issue to do with our website, but I just wanted to, I think the implication that we might be suppressing those reports is just not the case. They are definitely on the website. They might not be easy to access, but I can promise you they're definitely there.
Thank you, Michael. That's helpful. Can I take the gentleman in the front sitting next to David? Then Bren, then we have to end, I'm afraid, because we are out of time.
Thank you, Chairman. Robin Pike from Hertfordshire HealthWatch. A couple of very quick questions, if I may. One on timeliness and one on GP inspections. When there is a substantial delay in publishing the inspection from a hospital trust, as is the case with a London hospital inspected in April, and for whom I do not think the inspection report has yet been published, is there a possibility of publishing an interim summary?
So just more generally, this is an issue, the delay in getting our reports out. We're well aware of it. If you do spend the 3 hours, as David was saying earlier, viewing our interrogation at the Health Select Committees was one of the points they raised, and our answer was that there are a number of actions that we are already taking to speed up the delivery of these reports quite dramatically. And in the fullness of time, and I was very clear to say to the committee, this is a sort of couple of years out rather than something that's immediate, the other actions are immediate, then when we get to better use of digital technology, we will be able to make a quantum leap in the speed of getting reports out, because that's actually what needs to happen. I'm not sure, Mike, there is an intermediary step we could take.
Just completely agree that the delays in getting our reports out is not in any way satisfactory. What we do is we write a letter to the trust summarising the immediate feedback that we gave to the trust. If, of course, we are taking any enforcement action, as we discussed earlier, what we will then do is, as soon as the 28-day period of representation is over, we will actually make it public that we have taken enforcement action. So you can be assured that you would already know for that trust that had we had to take any enforcement action, that would already be in the public domain. But again, I just have to apologise for the fact that we have still got a small handful now of trusts where we have not yet got the reports out.
Thanks, Mike.
Thank you, Chairman. Question relating to GP inspections. There, in West Hertfordshire, there are now 3 independent providers of GP services, and one company has recently opened a very large building within which local GPs can rent rooms for private consultations. Are independent providers of GP services inspected?
Yes.
And rated?
That's a very good question. They are inspected. We've been looking at how we regulate independent providers of healthcare, and we've made a decision that those who are providing private, if you like, independent general practice, because there are private providers providing NHS services as well, we're now starting to look at those in the next phase as it comes forward. So they're very important. But we're already taking action when we have information or data on independent providers as a matter of urgency on a risk base, but they become part of the programme as we move forward.
Thank you very much. The questions. It's Christmas, Brennan. You very kindly sent me a Christmas card. Thank you for that. nice to see you.
3 very quick points, really. The first one, in terms of what Chris Day was saying about trust and the engagement. I think you could look at all that paper and boil it down to 2 things, really, which is exactly just that, trust and the relationships. I don't think we should use partnerships too much. I think that comes across to me sometimes as convenience, etc. And there's a clear difference between partnerships and relationships with that, really. The point I'd also add to that, really, is we shouldn't overlook how long it takes to build that trust up as well. We don't get it overnight. We have to earn it, etc. etc. And when Chris is talking about some of those community groups, really, that sometimes I've experienced of being consulted and consulted and consulted, and they don't see any real significance, and particularly in areas of greater need as well, really. It's really difficult. So don't overlook how much of an opportunity this is as trust, but also how much the challenge is to actually the time period, and make sure we're realistic with that. I also think, in terms of hearing about the website and whatever, really, and the developments around that, that one of the things that we also should look at is how more easy we can promote the e-alerts for people who want to say, I'd like to know, in terms of what the inspection of the acute trust, for instance. It's there and whatever, really, but it's just not easy. And actually, I think that's one thing that we can do without looking to develop the website and whatever, really, particularly a promotion. I know that's not applicable across all three sectors, but there is one sector in particular I think we could do a little bit better on, really. You would have heard me say this before, really, but I think the CQC, as in any other organisations, rises and falls on its people, in my view, really. Structures, systems, etc. are supported and whatever, really. And I just wanted to bring to the attention the board of inspiring people in CQC that I've come across. And you had one presentation from Chris Day today, and my dealings with Chris over some time now, whatever, really, is that he won't always do the easy things, but we always will do the right things that we can do. So it is easy to do the easy things. We know that. We all know that. But it's absolutely right to do the right things, and I think he's an exemplary ambassador for CQ. He's not the only one, but I'd just like to draw attention to one person.
Thank you. I suspect he's monitoring the meeting, since it's still in the public part, but I will pass that last part on. Thank you very much indeed. Ladies and gentlemen, that ends the public meeting. Wish you all a very happy Christmas. Thank you for coming today. Board, we need to do another short burst of work before we get a break for lunch, I'm afraid. So I just ask members of the public to leave us.